I'm a public health physician, so my thinking will be slightly more towards public health. Although it's in the clinical track, we do a lot of clinical as well as community work and policy work. So as a public health physician, we are actually the bridge in terms of translating clinical evidence into community and also improving the policy of the country. Right. So let me begin with a very simple truth. Do you not have to smoke to be harmed by tobacco? You understand the statement? I'm sure among all of us here, who smokes? Nobody smokes, right? So do you think that we can be harmed by tobacco even though we are non-smokers? Right? So it is very, very important that in our community we see children with recurrent EEs, we see pregnant women with adverse outcomes, and we see older adults with worsening respiratory disease, and many of them, they are non-smokers. So why is this happening? Yet everybody is exposed, right? And now I have to manage this myself. So secondhand smoke is actually not an individual problem. As a public health practitioner, we see that it is more of a system issue. So passive smoke exposure is often framed as an individual issue, but from a public health perspective, it is actually a systems issue. So a failure of policy reach, enforcement, and also social norms will cause all these things to happen. So in Malaysia, we see that the exposure remains high, and in some communities, not in within our region, more than half are actually exposed, especially in low-income housing. So where do you think most of this exposure happens? Is it in the public places? Is it in the homes or in the workplace? All of the above. So which area do you think is most impacted? Which has got the most second-hand exposure for tobacco? In the homes? Why do you think homes? Who smokes outside? I'm sure that the technology doesn't like me. Okay, never mind. So you're seeing that in the homes, it has got the most exposure for second-hand smoke, provided that there are smokers in the house, right? And I'm sure we are trying our best to make sure that nobody smokes within our fraternity or nobody smokes at home. Because in reality, if you look at the National Health and Mobility Survey and also our Global Adult Tobacco Survey, the recent one, 2023, and also NHMS, the recent one is 2025, our prevalence of smokers is slightly less than 20%. It's about 19% something. So majority of us are non-smokers, right? So we should be the ones having the bigger say and not allowing the smokers to rule our air. So in Malaysia, as I actually wanted to show you the NHMS and also the GATS data, but never mind. So like what a majority of you mentioned just now, the exposure happens primarily in the homes, and this is where protection is often seen as weakest. Hang on. Yeah, right. Never mind. So at home, the protection is actually seen the weakest. So why is it the weakest? Because we also see that the exposure is actually not random. It is disproportionately affects children, it affects pregnant women, and also low-income households. So if you look at this slide, it looks that the vulnerability is actually structural. And let me show you how exposure becomes disease. We start with inhalation of fine particles and toxins from the smoke, and also now we have to expand our definition of secondhand smoke. It's not just from the tobacco smoke, but also from aerosols from your vape and electronic cigarettes. So this triggers biological changes. It causes inflammation, oxidative stress, and also endothelial dysfunction. And over time, this translates into asthma, cardiovascular disease, and adverse pregnancy outcomes. So this is how invisible exposure becomes visible diseases. And local evidence actually reinforces this. We see increase in breast cancer, increase in breast cancer risk, and also increase in the risk of low birth weight with prenatal exposure. So this is actually from two local studies in 2021. The details of it, because I didn't write it down on the slide, it was for the breast cancer study. It's actually a study on serum protein and passive smoking status associated with non-smoking newly diagnosed women with breast cancer in Malaysia. So it's a case control study among 78 women with newly diagnosed breast cancer with 83 healthy controls. So what they found was that the risk is twice. So those who are exposed has about 2 times higher risk of getting breast cancer. And the conclusion is that secondhand smoke is an independent risk factor for breast cancer among non-smoking women in Malaysia. So for the second paper, it is among low birth weight and secondhand smoke. It is a Malaysian study, a cross-sectional study among full-term infants. The population is actually 555 pregnant women, and it's conducted in Malaysia, in KL and Selangor clinics. So what they found was that secondhand smoke exposure during pregnancy significantly increased the risk of low birth weight. So the real problem is that from a clinical perspective, all these are actually very meaningful, because we see increase in risk of breast cancer among non-smoking women exposed to secondhand smoke, and also increased risk of low birth weight with prenatal exposure. So these are meaningful outcomes among clinicians, and children are particularly vulnerable because they do not choose their environment. Most of the time, children, they don't have a choice of where they are or where they are living, and yet they are exposed at homes, they are exposed in the car, and they are also exposed in the social spaces. So these are the environments that we do not regulate. So Malaysia has made a very strong progress. However, do you think that the current policies is sufficient to protect children in our country? Still, there's still room for improvement, right? So although we have the new Act for tobacco control, but there's still parts where we can improve. The gap remains, especially in private and semi-private environments. So we must remember, partial protection is actually not protection. So we need to have full protection, and the best thing is actually prevention. So these are the policy gaps that we are able to see. Although we have strong public health, strong public smoke-free laws, there's always this weak enforcement, there's always the behavioral factors in it, and new products such as e-cigarettes, vape, which also interferes with the things that we are doing. We actually have solved the smoking in restaurants. Now people are not allowed to smoke in restaurants and eating places, but it quietly moved into their living rooms. So there's no specific law to enforce that people cannot smoke in their house yet. Until we have that, then probably there'll be a true smoke-free environment. There's no protection in private places. So in the Empower, NPOWER strategy, P is on protect, but for us to be able to protect all of us, we have to make it 100% smoke-free environment, which is not an easy thing, right? So this is where public health physician is more relatable in this area. Before that, I just want to show all the implementation of smoke-free areas in Malaysia from 2011 to 2025. Majority of all the states have got their smoke-free zones. And also in all states, all restaurants and eateries, it's gazetted as a smoke-free area. And expansion of smoke-free zones includes indoor and outdoor public places across all states and federal territories. This is based on the current Act 2024 Act 852. So there's this is previous in the previous Act, but the current Act it's 28 places which is gazetted as a smoke-free area. Empat larangan rokok. So as public health physicians, we look at all these shortfalls and how do we actually improve on the current situation. So this is where we are uniquely positioned because we operate across clinics, we operate across community, and we are involved in the policy as well. So we are not just treating exposure, we are preventing it. So what needs to be changed? So from clinic to community and to policy, there are several things that I would just like to put forth. That it is actually important to promote smoke-free homes. We do this under COSPEN. There's a lot of activities under COSPEN to promote smoke-free homes. And we need to protect children in cars. So if you realize parents who smoke, they smoke in the car, and that affects their children. So we also need to strengthen the enforcement and to also address the emerging products. So all these things are actually practical and also scalable. It's actually just the willpower among all of us. If you want to do it, we can actually make Malaysia smoke-free. So the message is exposure is preventable, vulnerability is actually predictable, so our action must be systemic. So let me just leave you with one question. So what is one action that you can take starting tomorrow, or maybe starting after this, right after this? that you can take so that the room or the air that we breathe is cleaner and smoke-free? Any ideas? So you can think about it, because if passive smoke exposure continues, it is not because we lack evidence. It is because we have not translated that evidence into protection. And as public health physicians, we are uniquely positioned to change that. Because protecting respiratory health is not just about treating the disease, it is about protecting the air all of us breathe. So with that, thank you very much.